And it started out by doing a kind of a white paper that we called Imperatives for Quality Cancer Care. And Alan, our CEO at the time, gave this report to Dr. Richard Klausner, who was the head of NCI at the time. And he called Alan immediately and said, "Why aren't we doing something about this?" Within 1 year, we had the Office of Cancer Survivorship at NCI.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello and welcome to the ONS podcast. I'm your host, Ruth Van Gerpen, a member of the 50th Anniversary Committee. Today's episode centers on a topic that continues to shape the future of oncology nursing, cancer survivorship. The American Cancer Society defines a cancer survivor as anyone who has been diagnosed with cancer, regardless of their stage or phase of treatment. Similarly, the National Cancer Survivors Day Foundation emphasizes that survivorship begins at the moment of diagnosis and continues throughout the individual's life. As of January 1st, 2025, 1 in every 18 Americans, approximately 18.6 million people, are cancer survivors. By 2035, that number is expected to surpass 22 million. This episode is part of our 50th anniversary podcast series. Please join us monthly throughout 2025 as we feature episodes exploring ONS's rich history and promising future. Joining us today are 3 of our colleagues, each of whom brings deep experience and expertise in cancer survivorship research, clinical care, and program development. Susan Leigh is a trailblazer in oncology nursing and survivorship advocacy. Her dedication to patient-centered care began with her own cancer diagnosis in 1972, shortly after serving as a U.S. Army Nurse Corps lieutenant in Vietnam. Susan is a 4-time cancer survivor, having lived through Hodgkin's lymphoma, breast cancer, bladder cancer, and lung cancer. Her lived experiences have fueled decades of work advancing survivorship care and policy. She was a founding member of Cancer Nation, formerly the National Coalition for Cancer Survivorship, and continues to be involved. Susan helped shape the national conversation on survivorship through public speaking, program development, writing, and publishing. She has also served on advisory panels for numerous oncology organizations, including the National Cancer Institute, ONS, and currently Hodgkin's International. Dr. Deborah Mayer is the Francis Hill Fox Distinguished Professor Emerita at the University of North Carolina School of Nursing and serves as a faculty fellow at the M. Louise Fitzpatrick College of Nursing at Villanova University. She consults widely with cancer centers and healthcare organizations to enhance cancer care delivery. A past president of ONS, Dr. Mayer was appointed to the National Cancer Advisory Board and was the sole nurse selected for the Cancer Moonshot Blue Ribbon panel. Dr. Timiya S. Nolan is an associate professor in the Division of Preventive Medicine in the University of Alabama at Birmingham Hersink School of Medicine, where she also serves as associate director for community outreach and engagement. Her research focuses on reducing cancer-related health disparities, particularly among young African American women. She leads efforts to implement culturally sensitive psychoeducation and behavioral interventions and was honored with ONS's 2022 Victoria Mock New Investigator Award. Dr. Nolan also brings a critical global and community-based perspective to survivorship. Thank you all for joining us today. Susan, I'd like to start with you. Tell us about the history of cancer survivorship and your involvement in its origins.
Thank you, Ruth. This is such an important topic for me. It's been my passion and my mission for many, many years now. Actually, I have survived for 53 years, and so I consider that a real gift. Rehabilitation was the very first way that survivorship ended up as part of looking at what happens to people after cancer. And Deb Mayer was one of the very first people looking at rehabilitation and looking at what cancer survivors do once they complete their treatment. So I always appreciated the work that she did. But with all of the awareness, the increased awareness about increasing lifespans, that all happens because of better diagnosis, better diagnostics, earlier diagnosis, development of treatments, and certainly combination chemotherapies, and now immunotherapy. So the numbers of cancer survivors is just really, really skyrocketing next to what happened when I first started in oncology nursing or was first diagnosed. So with all of this happening and the increasing numbers, an article by Fitzhugh Mullen called Seasons of Survival was published, and Catherine Logan Carrillo in Albuquerque, New Mexico, she took a look at this, and she had developed Living Through Cancer, which is what was a community-based program. And so she got in touch with Dr. Mullen, and they pulled together 23 people from around the country who had been working with cancer patients and cancer survivors at the time. Deborah Boyle, another oncology nurse, was the first one who was invited to this. She already had other prior engagements, so she asked if I wanted to go. I was so excited. I just was beyond myself that I would be within a group of people who actually did not minimize or dismiss the issues of longer-term survivors. This group got together. We decided to form an organization, which we eventually named the National Coalition for Cancer Survivorship, and which was just renamed Cancer Nation. But when we formed this, we initially focused on community development and sharing resources, and we wanted to join organizations from around the country to have them be members of NCCS so we could be working together. Certainly we have power in numbers that way, but none of the organizations wanted to do that. They eventually decided that they all wanted their own specific organizations for different cancers. The idea of having that kind of a membership did not work. The board decided that it would be much more effective if we moved to Washington, D.C. and really focused on public policy. So that's where NCCS has made its main contribution over the years and still does in the area of public policy. But we also had some oncology nurses and oncology social workers who were part of our group and often board members. And we decided to get together and do some clinical projects. And it started out by doing a kind of a white paper that we called Imperatives for Quality Cancer Care. I did the physiologic part. Then Betsy Clark, a social worker, did the psychosocial part. And then Ellen Stovall did the quality cancer care part. And Ellen, our CEO at the time, gave this report to Dr. Richard Klausner, who was the head of NCI at the time. And he read it, and he called Ellen immediately and said, "Why aren't we doing something about this?" Within 1 year, we had the Office of Cancer Survivorship at NCI. And once again, Deb had a major role in that too, as she was one of the interim directors. That was a major step in the right direction for the way we could actually get something done for our survivors. And then we also developed the Cancer Survival Toolbox, which was an audio educational program. We finally had about 10 topics, and each topic was a special session. And that was first on CDs and then discs. Now it's actually online. That was another program. In the 1980s is when we started this. And in the 1980s is really when we started seeing the development of different groups around the country. The wellness community was represented at the beginning of NCCS. Stanford was represented because they put out one of the very first newsletters that was written by or about individual patients, survivors. And then, of course, Living Through Cancer in Albuquerque invited everybody to start NCCS. And then in the 1990s, we really saw the rise of body part organizations where everybody wanted to really focus on the individual cancer diagnosis that they had. And of course, it started with breast cancer. And breast cancer ended up having about 5 different organizations within a pretty short period of time. And they all focused on something different. But mainly they started out focusing on education and getting resources to people. But then it really morphed into funding for research. The ovarian cancer group started their organization next in prostate cancer. And now just about every one of the major cancers has their own organization. So then we started taking a look at people who were living way beyond what was expected. And we saw people living into not only months, but years and now decades. And while we started seeing this group of people, weren't necessarily in oncology anymore, but they were being seen by their primary care doctor or other specialists. And so we really had to start taking a look at sharing information, really having a shared model of care. But we started seeing these late effects. And one of the things that I always thought would have helped if we had only had systematic follow-up of our long-term survivors from the beginning, we would have gathered a lot of data a lot sooner than we have. What we did is different doctors started seeing some of their longer-term survivors come in with different problems. One of the very first examples was Hodgkin survivors who had a long lifespan ahead of them, and they were coming in with breast cancer. Breast cancer was the very first one. And then they started taking a look at what was happening to the larger group, and now they've identified all kinds of risk factors. And the risk factors are certainly long-term factors, such as people living with fatigue, neuropathy, and they're also living with the fear of recurrence. So it isn't just physiologic, but it's also psychosocial. And psychosocial problems were actually the very first that we took a look at. Then the late effects, there, of course, is the potential for recurrence of the original disease, and then the development of other cancers that are different types of cancer, and then different types of system-related problems, such as cardiac, pulmonary problems, and infertility. There's a whole list of them. Another way that NCCS got very involved with looking at how we keep this information coming and how we really share care with our outside physicians is the development of survivorship care plans. And then we also hoped that we would see more survivorship clinics by now. But between trying to get people to develop care plans and clinics, it's been like pulling teeth. It has been very difficult. And a lot of this struggle to get this going has been, first of all, there isn't enough money to do this. There isn't enough time for immediate staff to take these on. And we just don't have enough staff as it is now. And survivorship is not a moneymaker. So it's just something that has to be done kind of on the side. We're now seeing the development of more community-based support programs, and they're not necessarily affiliated with the local hospital or a comprehensive cancer center, which is where they started out. The survivors themselves are saying, we can't wait any longer for the medical community, the healthcare community, oncology community to do the development of these. We need to take some of this in our own hands, and some wonderful programs are being developed. To end with, survivorship is now normalized. We hear about survivorship a lot. We're even hearing about it in other disease processes. They're taking on our linguistics, but it's part of the cancer continuum. And it seems like it's taken an awful long time to do this, but it's finally happening. Survivors themselves couldn't be more happy to do this.
Susan, can you share with us a specific project or partnership where ONS played an important role in cancer survivorship?
To begin with, ONS invited Debbie Boyle to do a session at the 1987 Congress. And that was shortly after we formed the organization. And so Debbie brought Fitzhugh Mullen and myself and a woman named Lamar Bomaretto, who had multiple cancers already. And we did a session on cancer survivorship. There was essentially no information out there about this brand new topic. So we essentially told stories of what was happening to us. And Dr. Nolan, of course, as a survivor himself, he really talked about looking at public policy and looking at the seasons of survival and how things change. So ONS gave us one of the very first platforms. And then I started a focus group for oncology nurses. It was a closed group. It was there so when nurses came to Congress, we could sit and talk with each other. That really didn't pan out too well. A few nurses wanted to meet every year. Some nurses didn't want to come at all. That eventually went by the wayside. I also developed a survivorship special interest group, and that was mainly because so many oncology nurses wanted to learn more about survivorship. So we had a SIG which went on for quite a while, but actually I don't even know what's happening to it right now. So anyway, ONS has been involved. It's been with any of the projects at NCCS. Oncology nurses are still involved, and they were involved in the development of all their programs.
Thank you very much for the information, but also for everything that you have shared and contributed to this particular field. Personal reflection. During my term on the ONS Board of Directors, I had the privilege of helping develop that cancer survival toolbox with the NCCS alongside you and others. Your story, your passion, and your commitment to cancer survivorship was really what inspired me to develop programs at home in our local community for our survivors. Very indebted to your contributions, but also to the inspiration for me, but I'm sure for many others as well. Now let's hear from Deborah and Timiya. Deborah, can you please tell us about your background and what initially drew you to cancer survivorship?
Well, thank you for having me. And I loved hearing Susie's story. We go back decades in this area, so it's nice to hear her talk about it. I became a chemotherapy nurse in 1975. And one of my first patients sat me down and said, I expect my doctor to try and cure me of my cancer or to keep it under control for as long as possible. But if nobody asks me about how well I'm sleeping or whether I've had a bowel movement, my life can be pretty miserable. Somebody needs to be paying attention to those things. So that set the platform for me as far as quality of life and symptom management. I then, after the next few years as doing chemotherapy nurse, always involved in clinical trials and doing some phase 1 trials later on, remember how shocked I was hearing about the first patients developing bladder cancer after having Cytoxan or developing leukemia after taking Alkeram for breast cancer, which was again in the 70s, that we were actually creating new cancers from the cancer treatments we were giving. And I was devastated by that, thinking I was trying to help these people and I may have been also harming them. That perked along and, I really tried to focus on some of those issues for the people I was taking care of. And when I became ONS president in the 80s, I was the 4th ONS president. We were given a cancer grant to do something with our presidency. And that was when I really wanted to bring attention to rehabilitation as a means to address cancer survivorship issues, because we had a very treat 'em and street 'em attitude. We gave you your treatment and we sent you home and you had to figure out the rest. And there wasn't a lot of knowledge or support to help you put your life back together again in some form or fashion afterwards. And so in that process, it was an interdisciplinary group of professionals that we sat around and tried to come up with what was an appropriate position statement, because ONS was just starting to do position statements. And so we developed a first position statement on cancer rehabilitation as a means to address survivorship issues in 1987 to 89. I continued to do work at the National Cancer Advisory Board, which I was appointed to after I was ONS president. And that was when Anna Meadows was appointed the first director of cancer survivorship. So worked with Ellen Stovall on that aspect and saw that come to be. And then Julia Rowlands took over after that to direct the National Cancer Institute's efforts in survivorship issues. There was a lot of pushback from oncologists and what have you saying, well, you'll figure it out if you live long enough after your cancer. What is this survivorship stuff? It's sort of nebulous. But I think there was a growing momentum of us wanting to focus on more than the tumor that happened to be in a person, and that the treatment and the approaches were to get the tumor under control, but the effort to help the person manage all of this and integrate the cancer experience was missing. And in the position statement, we really talked about the cardiac rehab model. When somebody had a heart attack, they weren't just sent home. They were sent to cardiac rehab to sort of learn about healthy eating and about exercise and all those other kinds of things. And also hospice was a model about how that got reimbursed for through Medicare as providing that kind of service. And in the early days, hospice was almost totally cancer until AIDS came along. So there were models to look at that we weren't, as far as learning lessons about how to bring that into cancer care. The next steps for me were when I went back to school for my PhD, I did my dissertation on health behaviors of cancer survivors and realizing the huge gap in the care that they were getting for anything other than their cancer. We were still focused on their tumor and on treating their tumor, but we were missing the picture that if the cancer didn't kill them, their heart disease would, and they would develop diabetes and other things. And so there was a real gap in linking primary care into the oncology picture, because in the early days, people pretty much died. So we took care of the whole person until they died. But as people started living longer and longer, we were missing all these other chronic illnesses that would contribute to their quality of life and overall lifespan. So my dissertation put me on a different path. And I think the second part of my career was really focusing on, instead of just relieving suffering and the quality of life issues, is really looking at cancer care delivery and how we could do a better job of doing the team of teams that people needed to have their issues addressed. That led to a lot of health policy work, including being the first nurse on, at that point, Vice President Biden's cancer moonshot. And that eventually led to my being invited to be the interim director of the Office of Cancer Survivorship, which I did for 2 years from 2018 to 2020, just before I retired. And it was a way to sort of harmonize what we were doing with research funding at the National Cancer Institute to help identify where the real gaps were in cancer care and in symptom management to help survivors live better and longer lives. As time went on, I started shifting into health policy. I did a lot of work with ASCO and survivorship care plans. There had been for a long time a biennial cancer research, survivorship research conference that was co-hosted by the American Cancer Society and the National Cancer Institute, and I think NCCS. And then that sort of went away when ASCO had a survivorship conference, which would then merged into quality of care conference. So the issue of where does survivorship live and who owns it is still up for grabs, but there's a larger group of people who are interested and care about the issues that fall under the large umbrella of survivorship. And that's why I'm so glad you have Dr. Nolan on as well, to be able to talk about the next wave of researchers and clinicians who are going to be addressing these issues. I think Susie's work and then some of the things that I did brought this to the radar screen, but we still have a long way to go to really address the issues that were raised during the last 40 or 50 years.
Deborah, thank you for the introductions, for the information, but also for the significant contributions that you have made and hopefully continue to inspire many others to continue this work.
Thank you.
Timiya, what was it that inspired your work in this field?
In terms of what got me started, my inspiration for survivorship is both professional and really deeply personal. My brother is a 16-year survivor of renal cancer, and I have many other family members who have faced brain, breast, and lung cancers. When I began to think about what I'd like to do in nursing, it was very, very apparent that I needed to do something that was close to my heart. And so when I thought about survivorship, it really was not an abstract picture or a group or a statistic. I was seeing, my loved ones and the needs that they have. I just remember what it felt like to want more time with them, to wish for normalcy, to reconcile how cancer changes a person and a family. And it leaves some things, beautifully the same. But professionally, my journey began as an RN, rotating through 6 acute care units. And I ended up having my first permanent role on a hematology oncology unit at the University of Alabama at Birmingham. And there, I literally saw patients just like my family members who were fighting for their lives. And despite the severity of their illness, they wanted more than just survival. They wanted to have meaning. They wanted to have dignity. They wanted to have impact with the time that they had left, whatever it was. And so those experiences planted a seed in me. And that seed was that cancer care must extend beyond treatment, and we need to embrace really quality of life. It was great that at UAB, I had the great fortune of meeting some other wonderful nurses. And one such nurse was Dr. Karen Meneses. She really helped me to deepen the commitment that I'd already had. And so when working with Dr. Meneses, I did a dissertation, completed it in 2016. And it was one of the first to structure how we understand breast cancer survivorship in young Black women. And so doing that qualitative work, it really opened my eyes to the intersections of race and age, culture, and survivorship. And it showed me really how critical it was to design interventions that speak directly to the realities that our patients are living in. As I thought about survivorship, certainly beginning at diagnosis, I began to kind of build on that work and build on the thoughts that, all right, I need to be a catalyst. I need to be able to really understand what quality of life means for populations of individuals and really help to try and create or co-create interventions with those individuals to improve their quality of life. And so both perspectives capture what I saw in my patients and really what I lived through my own family. This continues to inspire me to ensure that every survivor that I see, every survivor that others are seeing, that they're supported and certainly that they're celebrated.
What an interesting story. You know, we often think about the contributions that our family has provided for us, but yours is remarkable. I'm excited to see where this leads for you in your future. Deborah, I'm going to go back to you here with another question. How has the landscape of survivorship evolved over time, and what challenges do you see remain?
We have evolved. The fact of the matter is that people know what the word means in a broad sense, even if their work is a subsection within it. That has happened over these decades. I think it's still looking for its proper home as to whose professional responsibilities it is to address the issues that arise. There needs to be better partnerships with primary care and the cancer team. And diagnosis and treatment has gotten very complex with all the new things that we've learned about molecular biology and matching the tumor profile to the right treatments and things like that, that I don't see us breaking away from, again, that focus on the tumor and getting the right treatment aligned. But there needs to be the people who are seeing who that person is going through this and not lose track. And hopefully that's both within the oncology team and the primary care team. So it's really a team of teams. My feeling in oncology is we broke it, we bought it. You know, like when you go into an antique store, it's our job to really help work with the patient and their families about what to expect and what they need to be doing to live the healthiest life they can and how to accommodate and address the changes that they experience, because life is different after cancer for a lot of reasons. And as Julia Rowland has been one to say, that you may be cancer-free, but you're never really free of your cancer. It may go back in the rearview mirror as time goes on and you're doing well, but as many of us can attest to who develop long-term or late effects or new malignancies, about 20% of new cancers occur in people who've had a previous cancer, so they bring all that knowledge and experience to their second cancer or third cancer or fourth cancer, and then things get compounded. So I think whose responsibility it is to pay attention to these things. How do we work in multidisciplinary teams so that somebody's paying attention to these things? And how do we incorporate the patient and their family without overwhelming or drowning them in this? Because I think what's happened is we have shifted the focus of care from being inpatient to outpatient, and now we're shifting care to home care, often without preparing patients and their families to do that or to give them the knowledge and skills they need to be involved in that. And so I think it's part of the bigger cancer picture of where we need to be going and helping people manage all of this. I think we're developing a lot of bright young stars like Dr. Nolan who are paying attention to areas of this. We still need to keep somebody thinking about the big picture implications of reimbursement issues, about sites of care and who delivers care and how the care is going to be delivered. And given that there's too few of us and too many cancer survivors, alternative ways to delivering that survivorship care, whether it's survivorship programs, training, telehealth, artificial intelligence, we're going to have to rope in a lot of the new tools that we're getting to help address these issues, not just about the diagnosis and treatment of a cancer.
We do have work to do, don't we?
Yeah, we do.
Timiya, looking ahead, where do you believe we need to focus next to strengthen survivorship care?
I think that Dr. Mayer really hit the nail on the head there. You know, we're looking at right now, 80 million cancer survivors just here in the U.S. and probably by 2035, somewhere past the number 22 million. So survivorship is no longer the exception. It's really the expectation. And so we need to be able to address not only the cancer outcomes, but really the lasting effects of treatment and overall quality of life for survivors and their families. And so I believe our next focus really should be on making survivorship care equitable, accessible, coordinated for all. And so really stressing the fact that supportive care is essential and not optional. And so that means addressing the physical, the psychosocial issues, financial sequelae, as was mentioned for our survivors, and doing that for years to come. And so I think it's really, it can't be said enough that a critical piece of this is strengthening those transitions to care. I really think that all too often survivors finish that active treatment, they leave their oncology team and they feel abandoned. We've really got to reprioritize the way that we're working toward our survivorship care planning and have clear goals and clear ways that we can move seamlessly through from oncology to primary care and to community resources even. As we think about how we can do that, we learn in small spaces and then, of course, scale up to others. And so another focus should probably even be global. Since the early 2020s, I've actually had the privilege of working with the National Cancer Institute's working group on cancer survivorship in Africa. And together, we've been building a bridge really to try and understand what can we take from the context that we have here in the U.S. and adapt that to something that can be sustained over in Africa and countries like Ghana and Kenya, and really recognizing that survivorship there looks different. It's shaped by different infrastructure, different cultural norms, certainly different resources that are available. And that global work really informs my vision here at home as well, because it reinforces that survivorship is not one size fits all. So going really back to the fact that we've got to work with our different communities, work with our different populations, but then also understanding the individual pieces that color the way that survivorship looks for each of the folks that we're seeing. Some of the other places that we need to go next are really thinking about how can we innovatively deliver on these priorities. And so can we use artificial intelligence to scan patient records and identify survivors who are most at risk and falling through the cracks? Can we target outreach to those individuals with our resources that we have, reaching out to those who really, really need it most to ensure that those folks are connected and prevent those leaky gaps that we often see in those transitions to care? And I think that as we learn more about AI, certainly we're pairing that with the human side, with those navigators, those nurses, those community health workers who can walk alongside that survivor in their home. That really is what I think is where we should go next. And as the Associate Director for Community Outreach and Engagement at the O'Neill, I see firsthand how strengthening survivorship also means bolstering healthy lifestyle behaviors. So cancer screening, nutrition, physical activity, stress management, these are all the foundations. And we really need to be able to learn more about the integration across each of those pieces and working them into every level of care, all the way from the clinic to the community.
Those are exciting ideas and opportunities ahead, I can tell. Thank you for that. As we are nearing the end of our episode, I'd like to ask you each to share with us some personal reflections. Susan, I'm going to start with you. What accomplishments in your cancer survivorship work are you most proud of and why?
I'm probably most proud of getting over my introversion and being able to get up and speak to a large group. And a lot of that was because I was just so passionate about it. And I could not be told that I was wrong. You know, survivors have their stories. Their stories need to be listened to. I actually started out by telling my story, which I was criticized for by a number of different professionals, saying you should never share that kind of information and talk about what's going on with you. But I realized that the best way at that particular time, when we didn't have a lot of information available, is that the way people could relate to this concept of survivorship was to see an actual survivor. I have turned into this incredible case study over the last 53 years, and I was hospitalized a couple times recently, and one of the residents came in and he said to me, "Can you tell me how you were getting through this?" He said, "I want to learn from you." I just was beyond myself that that's the kind of questions I'm getting, rather than saying, "Oh, you've lived this long, you've lived a good life, you should be happy that you're alive." I think that's a change. That's kind of a reflection of the work that I did for so many years. I was not the researcher. I was not the major writer. I was not the identifier of a lot of the risk factors. but I spread the seed. I took all of that information from different sources and shared that with all of the audiences that I spoke to. So I was called a seed spreader, kind of the Johnny Appleseed of oncology nursing at that particular time. And then once we saw academia step in and say, we need to get good data about what's going on here. Once that happened, then my stories, the stories of that were from survivors, started decreasing, and the presentations were given more from the academic standpoint. So anyway, I think that I did make a difference. I never will be able to quantify it, but just that we now know the term survivorship, like Deb said, it's still not kind of set in stone as to what it is. It's a concept. And what I didn't mention early on was how we got to the term survivorship. And it was because of the stages of survival. But what I've now found is that we've added on to that stages of survival, which we looked at as an umbrella concept that then dealt with all of the different stages and the process of that survival that included both physiologic and psychosocial and all of the other types of issues. One area that I was questioned about a couple times was what happens to pre-survivors? Can they be part of this whole context of survivorship? And I got to thinking, my God, people who are living with genetic issues that they know that something could happen to them in the cancer related, they need to be included in under our umbrella of survivorship too, because they certainly need support. An area that I was also particularly concerned about is the original way survivorship was defined is they excluded end of life. And I thought if there's ever an area that needs to be included in this survivorship continuum, it's end of life. It's like, what in the world does every one of us think every time we have a new diagnosis? It turns out that with the Cancer Survival Toolbox, the end of life module is the most asked for. It's something that I look at survivorship as a real continuum. Just as Dr. Nolan said, it starts in the very beginning when you have your cancer. And now I'm saying it starts even earlier than that, when people are worried about if they would get cancer or when they get cancer. And one other thing, I've been involved again with NCCS. I hadn't been real involved for a while. I'm now on a couple committees there. And the level of advocates that we are seeing nowadays is phenomenal. And organizations like NCCS and then the breast cancer group has had creating advocates for a long time. The different types of disease-related organizations are helping their advocates learn how to be better advocates. And it is just amazing to me to see how excited these survivors are to learn how to go up to the Hill and talk to their congressmen. And of course, it's a very, very difficult time right now, but they were adamant that they go during their last meeting. So that makes me feel good, because when I started out, I was on every committee I could think of, and every different group that met, they had a survivor sitting on it because of what Ellen Stovall would stress. We need to have survivors sitting at the table when decisions are made, whether it's about types of care, whether it's about research, whether it's about anything. I would sit there and I had no idea what I was doing. I was sitting there as a survivor. And what the advocates are learning now and what they're actually putting out is absolutely phenomenal and gives me great hope. I think, like Deb said, when we see researchers and people like Dr. Nolan, who's really embracing this, it really gives me hope that it's going to continue to spread and we're going to get better and better care.
Thank you for your stories that you have shared. Personal stories over the years has made a difference, and your ongoing work in survivorship will continue to make that difference as well. Deborah, what moments stand out to you and what continues to motivate you?
I've been an oncology nurse now for 50 years, and the things that stand out are twofold. One is the people I've helped take care of and their stories, and you just never know what impact you have. You may find out later on a word you said or a gesture meant something that you had no idea. So that's the stuff that keeps you going. The second is I've spent my whole career trying to share what I've learned with others so that they can build on that. And that's been with my students, with the other professionals that I work with, et cetera. And so for everything I've done, for all the papers I've written, for all the jobs I've had, the most meaningful thing for me is the people I've mentored so that they can carry on the work, much like Susie has said, and to feel like there's a next generation who's going to take this the next step, the next level that needs to be. I'm not continuing to be motivated. I have retired from this work. I feel like it's time for the next generation to take it further. And I think I'm going to be watching from the sidelines with great interest how that is. I also have had my second cancer now. I'm just amazed at the treatment I got the last year and how much has changed from when I started 50 years ago. I now get a blood test every 3 months to look for circulating tumor DNA cells. I don't get scans and tests, et cetera, to see if the cancer is coming back. I mean, that's pretty remarkable. So the science of how to diagnose and treat these cancers has come a really long way. But it also means it's changing the face of survivorship, which means I'm out on my own. Every 3 months, get a blood test and hope all is well. But we have to think about where we let people go out on their own and what kinds of supports and services they may still need facing their history of cancer. My biggest accomplishment, I think, of anything that I've done is just in mentoring my students and those that I've worked with, and I'm very proud of that.
And I know that you have made a significant difference, probably more in some cases than you really understand and are aware of. Timiya, looking toward the future, what is your vision for cancer survivorship and the programs that support survivors?
I want to start by saying certainly we can't think about the future without acknowledging the past and also the present. And so I'm very, very grateful for the body of literature that has been written and developed by my colleagues here on the call, and really that it is firsthand information that has come from the heart, but also certainly strengthen the field of science. As I think about the question that you asked, thinking about the future, my vision is that survivorship is embraced as part of cancer care from day one. I think we've had many organizations that have long emphasized the survivorship begins at diagnosis and continues for life. And treatment today, it's no longer designed for just the maximum immediate effects. Increasingly, we're considering the long-term health, we're considering functioning, quality of life, and the shift must deepen. I envision that survivorship care is comprehensive, that it's seamless. As I mentioned earlier, thinking about global, and that survivors should never feel like they fall off a cliff once active treatment ends. Instead, that oncology teams, primary care, supportive care specialists, and community partners work together across that continuum, and that palliative and supportive care is not reserved just for the end of life, but should kind of ebb and flow, wax and wane as survivors need change. Survivorship should really balance cure with comfort throughout. Each is given equal priority. So that's kind of where I want to see the future of survivorship to go. But I think even more broadly, my vision also looks deeper into the discovery science. And we need to ask, what can our genes tell us about cancer? The answers have profound implications for better treatments, better outcomes, and fewer adverse effects. And at the same time, really considering the exposome. So the sum of environmental, social, behavioral exposures, and how they color survivorship, it's just as powerful as biology. And so the future of survivorship lies at the intersection of genomics and exposomics, and where we can predict who's most vulnerable to long-term effects and design tailored interventions. That discovery can be matched with collaboration. I really believe in community, academic, government, and industry approaches to survivorship as well. We can no longer operate in silos. We really need to learn how to walk across the aisle, build bridges as we can so that we can do this work together. Because we know that communities bring lived wisdom and context, and academicians bring the research and the ability to create the evidence. The government brings policy and public health infrastructure, and certainly industry brings innovation and scalability. But also in this new paradigm that we find ourselves in, the industry may also bring the dollars to be able to help us to do even more work. And so together, these partnerships can ensure that we get to the end goal, that we have equitable, culturally responsive, and sustainable survivorship care that's really drilled in and evidence-based. And certainly, I think, it goes without saying that technology is here and it's here to stay. And things like AI will help us to integrate genomic and clinical and exosomic data to anticipate the needs and personalized care. But it's the trust, it's partnerships, it's shared purpose that makes survivorship programs work on the ground. What I see, firsthand, it's essential that we pair discovery with action. So screening, lifestyle support, programs that meet people where they live. It's totally essential. It's totally an issue for all of us, both here in the United States, but certainly also abroad. My vision is really simple. Survivorship should mean more than survival. It should mean abundant life, supported by systems that are united in a purpose. And survivors deserve not only more years, but better years. And it'll take all of us across our multiple sectors to make that vision a reality.
Timiya, I will tell you, listening to that, the future, I believe, is in great hands with you and with your colleagues to lead us in this ongoing work in the area of cancer survivorship. As we conclude this episode, I'd like to thank each one of you as our guests for joining us and for sharing your wisdom, your stories, your perspectives, your challenges, and really where you see things going. Your work continues to inspire the oncology nursing community and to elevate the care of cancer survivors everywhere. I think it's clear that regardless of where we live or work, we are united by our shared commitment to high quality, compassionate care for individuals living with and beyond cancer.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.